Great, good. Nice to be here again. I have got so much to talk about this week. It's not funny. It's not real. And yes, I changed my shirt. Good. We'll start a bit early next week and see if we can get through it. So I'm glad you can hear me. I'm glad you can see me. We've got quite a lot to talk about in terms of the diaphragm and the respiratory stuff. And I've got some videos to share with you, both from the dissection perspective and also from the some practical stuff as well. And I've got a little file of some stuff I've written with some ideas on the lymphatic aspect. So the first thing I wanted to talk to you about was the idea that, again, we have in our world, in our Western world that most of us are in, and a Western medicine, a medical approach that we have this idea of having to treat an illness, a disease, in this case a virus, and yet there's so much that's demonstrating to us that potentially we might have an issue in relation to air quality. So some recent studies have shown us that air quality, where there's areas where air quality is particularly poor, the death rate is statistically much higher. And so why is that the case? Well, obviously you're having to deal with the respiratory aspect as far as that's concerned. So you've got air quality, but who is getting sick? So you get people that are getting sick, and the people that are getting sick are the people that are again, there's an older quotient, but age and illness aren't necessarily synonymous. You can be old and you can be healthy. So what we're seeing is people with existing respiratory illness, existing heart disease, COPD, smokers, obviously. Obesity has a high incidence in relation to the idea of what's going to happen. This virus is a respiratory illness. So can we prevent the virus? No, but can we prevent us from getting seriously ill from the virus? We can certainly have a go at it. And again, what is killing us, or what the death rates are people whose respiratory systems are shut down. Then it compromises the immune system, and we end up with situations where people just they can't fight out and they get organ failure or pneumonia. It used to be called the doctor's friend, because the old man's friend, because he fell asleep. So there isn't there's a saying that says, when's the best time to plant a tree? 20 years ago. When's the next best time to plant a tree? Is now. So when was the best time to get fit? Well, if you were 55 or 60, 15 or 20 years ago, but the next time is now. And so the idea that if we are going to be seeing something like this and coming again, that we need to actually create some type of prevention. Okay, so the prevention is be less fat, be fitter, have better respiratory illness, give a respiratory function, give up smoking, and do all those things that you've been meaning to do. And one of the problems that we've had as far as, say, herd immunity is concerned is that it's all very well having herd immunity in a herd that is otherwise healthy. But if you put a virus out into a herd, and we're not exactly sure that we're going to get that immunity anyway now with some of the data that's coming up, and that herd is fat and smoking and has poor nourishment, then you've got those kind of situations going up. So the role that we all have as movement therapists, manual therapists, is absolutely vital, and we shouldn't underestimate that importance. And I think it has been underestimated. And there's an army of us that could be, it would be interesting if we could go back 5 years and say, right, everybody, let's just get everybody to have as much manual therapy as they possibly could, and we can go from there. So without further ado, let's get this started, and hopefully we'll. There we go. We'll start our presentation. And the first thing this evening is, everybody, we can have a little breath. Now, I can't see your chat, by the way, so if you're chatting to me, then I'll pop backwards and forwards after a few slides into the chat room to have a little chat, and occasionally. So our first thing today is to have a little chat and a little breath, and to get ourselves orientated in terms of where we happen to be around the body, and to think about where exactly are our lungs? What's the space that we have? So if you want to just draw out the shape that you think your lungs take up, the space that your lungs take up, where they go, and if you've got anybody else in the room, then see where that works out. And let's have a little look and see what the space is taken up with. So what we've got going on here is our thoracic cavity. In the thoracic cavity, in the abdominal cavity, is one of those things that again sort of tends to upset me a little bit, because the definition, here we go, there's our diaphragm. This is thoracic, this is abdominal. But if you imagine that this is a screen that goes across the two of them, there's not much to it. So yeah, that's what we're dealing with there. We're just going to fill this. We're going to fill this space up and see what it looks like as we just fill the space up. So we got our first one is going to be coming into here, which is some muscular structures. We got our aorta coming down the back there as well, and we're going to start to fill up into our abdomen, some kidneys, popping the spleen at the back into here, and we'll fill up some space. And the first bit that we see that sits conveniently is the heart. Of course, the heart doesn't sit sort of simply on top of the diaphragm like this. It sits it's sort of joined up with a bit of a tendon there, but we'll come back to that. We'll be doing that a little bit more. And we're not going to hang about here too long, but there's a lot of stuff that goes in here. We've got our right lung and then our left lung, and we've got a big old liver in there. This is a stomach that's popped our stomach into here as well. Here's our liver, and we've got a sort of the beginning of the transverse colon, which doesn't look in the place that I would normally expect to see it, but never mind. You know, hey ho, it's you never know what you're going to get when you get some anatomy. This fella here, you'll hear me talk about this when I do a whole session on this. It's called the greater omentum, and it's an apron that hangs down. It's one of my favorite bits of viscera, and I do rather love the greater omentum. We'll talk about that in some more detail in the future. And by here now, so we've got our rib ceiling across the top here. There's our ribs, and hey presto. So this sort of area is full up with, as I said, with a lot of stuff. But I want you to imagine, if we just go back to the previous slide, you're going to be seeing all of this contained in a bag at some stage throughout this evening. And so this whole shebang, if you like, all of this is contained in one bag. And the outer bag is a muscular bag, and the inner bag is a sort of visceral bag. What I wanted you to look at initially was just how high up those lungs go. Now, with the jugular going there, you can't tend to see how far it goes, but have a little look and we can get an idea as to how high above our collarbone the rib cage is going. So it's quite a remarkable place that we have, which is that which are those lungs right up into there. We just move this down ever so slightly. Okay, what do we got? So again, what we can see here, a few little areas to look at. Little area to look at here. So we've got our lungs. This is a view from the back. So remember that most of the lungs are an organ of the back, and you've got a little recess here. This is the costodiaphragmatic pleural recess. So this is all diaphragm. This is all diaphragm through here, and then these are the lungs. And the lungs create this tail. So the top of the diaphragm is sort of right up. If I just trace that around here, so the top of the diaphragm is right up in here. And then this is the base of the lung coming down around here. The left lobe of the left lung has 2 lobes, and the right lung has 3 lobes. But imagine that you've got, these scaps are creating effectively a pressure onto your back. So when we start to talk a little later on about accessory structures, you can understand that the movement of this rib cage and the space that's being created by the accessory muscles of respiration are creating space in the thorax, and that's really what we're looking at. And we'll look at that in some dissection as well. So let's get rid of that. It's unfortunate. So let's have a little look at our lungs and see where we're going to go from here. So the lungs have a lining around them. They have a pleura around them. And this is a particularly strong pleura that we're seeing. And I wanted to show you just the size of the lungs. And what I've done this week is I've taken the sound off, because I was talking over them last week. So I've taken all the sound off. So hopefully you'll have no sound as we start to talk. So what we've done in the lab is we have the great facility to be able to have these very soft fixed cadavers, and everything moves very beautifully, and as a result we get these lovely filling up of the lungs. So before we start, as with anything, I do want to take a word and a moment to give thanks to the donors and the donor program and the families. All our donors have given their bodies up so they can be examined and we can learn from them. And this was their last wish. And most of the pictures that you'll see tonight are from donors that would otherwise have been rejected by the universities or the medical schools that we work in around the world, that have been turned away simply because they were too scarred or too old or too large in some instances, and so they get accepted into that simply because a class that I'm running will be turning up. So but it's a marvelous thing that the donors do, and we're really, really grateful. So thank you very much to all the donors and their families for this opportunity. And respect for the donors is the core principle that runs throughout all my classes. But what the donors wanted was people to be able to learn and help other people from their gift. And so even if you learn something from here, then with these donors' gift will have been purposeful. So I'll just have show you this little lung here. This is a very interesting, actually. This is quite a diseased area. So what you've got is a very thickened. I'm just going to make this quite small here. This pleura. This is the sort of the lining that's going to seal off the lung into the thoracic cavity. So you can see the ribs coming from around to here. These are the tails, the diaphragm down into here, and this pleura, this sort of lining, if you like, this parietal pleura, is lining the inside of the rib cage. And if we just go across to the opposite side, you can see that this lung is fairly small and diseased. So this lung wouldn't be inflating. You wouldn't be seeing anything going on as far as this lung is filling up is concerned. But the diaphragm is still here. This is the muscle of the diaphragm. If I clear that again here, this is the muscle of the diaphragm we have going down into these tissues here. And so this pleura will cover the lining of the diaphragm and blend that diaphragm into the transverse abdominis. But what we've done here is taken this away, and this pleura will wrap across and effectively create a closed structure for the left lung, and in this case the heart. You've got the mediastinum into here, and then you'll have another lining, of course, well, same lining if you like, closing off onto the right heart. So the lungs are completely enclosed in their pleura. Let's have a little look at what they look like when they're out. You can get the idea of them if you remember that shape that we had before. And we're going to look at this little video here now. Hopefully it's loading. Okay, and we're going to play the video. There we go. And you can start to see that what we've got is we've got this. We've got a tube. This is looking at it from. You'll see it come down to the. This is from the front initially, and the heart is. This is the heart, sort of down into here, down in this area here, yeah. And the right lobes and the left lobes. And this is sliding surfaces. So you can see how the lobes overlap. And what you're looking at from here, this is the underside of the heart here, yeah, where the heart will be sitting on top of the diaphragm. There's a tendon that goes onto the diaphragm. And so we've got a tube that's going all the way down through the trachea that's fully inflating those lungs. These are quite normal in terms of they're quite healthy lungs. The blackness is something that you'll see that is in every lung. Which is the sort of carbon deposits that people have if they live in a city. The blackness on the back of the lungs here is just where the blood has pooled into the thoracic cavity. There's nothing much you can do about that. So we're looking at the lungs from the back here now, so you can see the space that those lungs are taking up. Just give me a thumbs up. See, people are being rude about my shirt. So you can see how the lungs wrap themselves around the heart. And you can also get the idea of how this lung is going to be pressing down. And did you remember how I said about how the doming of the diaphragm comes up? So the lungs wrap themselves around the doming of the diaphragm. Yeah. Underneath that, what you're going to see, so if you're going to see at the back, you're going to see the spleen would be almost in direct contact with the undersurface of the lung, and the liver and the stomach. Yeah. Beautiful. They're like wings wrapping themselves around. It's very cool. There we go. There's our lungs. So beautiful. I just wanted to actually pause that if I could. Let's pause that a second. Okay, I'm just going to go back to one little point in here if we can get that. So this again is what I'm going to show you here. Is this base of the heart here? You won't quite see it in the same amount of detail as before. So this is the underside of the fibrous pericardium. So the heart is sort of encased in this fibrous pericardium, and there's a little bit of tendon that sits on the top, and it's quite hard to get away from it, but it can be done. So yeah, we'll have a little look and see what the rest of it looks like. Okay. Let's go back to our files. I would call that I always call that the the money shot when we get to that point in the dissection where just the lungs inflating are just the most amazing thing to see. It's quite an incredible thing. There was a nurse that came on a nurse practitioner that came on a class, and she said, she'd studied her anatomy and she's fairly versed. Yes, I did a video on my website on terms of the testimonial. She'd done her anatomy. She's a very skilled practitioner. She just had kind of no idea that's what they look like, the space that they filled up. So when she's saying next time she's listening to a lung, it's going to be a very different matter. The question is it a normal amount of inflation? Yeah, it is. It's the only thing that's restricting that inflation would be the space that you have. Now, bear in mind, of course, that you're pushing air into those lungs. You're not breathing in. So the only limit you have is not so much the lung capacity that you have; it's the capacity of your body to actually get that air into you. Okay. Let's go back to our slides again. So that was our lung, the sliding surfaces. So what happens if we don't have a sliding surface? What happens if we end up without a sliding surface? So what we're looking at here is we're looking at the right side of a chest, and you can start to see again some of the structures that might be involved in respiration. So we've got the bottom of the lung is to here. I'm going to change that color because it's a little bit of a dark color. So the bottom of the lung is here, and you can see this space. And I mentioned earlier on, you've got the costodiaphragmatic pleural recess. So look at all the ribs that you still got that aren't touching into the bottom of the diaphragm. So this would be the diaphragm in here. I'll just clear that again. You can see that this would be the diaphragm into here, and then you've got all this space that you would have where the lungs would fill up. And I don't know if you can see this in here, but this is this sort of smooth surface. We looked a little bit earlier on about the area that the lung is containing. This is the pleura here. This is the parietal pleura that's sitting across the top, and then there's another lining across the top of the lungs, which is the visceral pleura, the sort of the skin of the lungs. So again, those lungs are encased in that. So we're going back to the previous chap. So we go back to this previous chap here. I just wanted to show you a normal set rather than a different set. So this is this chap here who's this person here who had quite a diseased lung, and you can see that we're peeling away this tissue, the pleura, away from the surface of the lung. This is not how it would be. We shouldn't be seeing any of this into it at all. And as we progress again, you can see that it's very stuck. There's no movement in the spaces between those lobes, and of course the right lung here is completely diseased. It's not functioning. You'd have very little lung capacity there. So you may well be looking at somebody that had obviously a diseased lung. Very little doubt about that. We didn't have the post-mortem for it, but we couldn't be sure. But almost certainly going to be a diseased lung. There's a lot of stickiness to the pleura. It's not sliding around. So you'd probably say that there was some lung disease going on there. So what it was, it's hard to say. So this is what it's going to look like. This isn't the same image, but this is what it's going to look like if you ended up. There's a little adhesion in here. It's quite hard to get the focus, but you can start to see this sort of stickiness into here, where you've got. I'll just drop the size of this out. You get this sort of stickiness of this tissue coming down. So what's creating that? What's causing that? Well, the principle, I don't know if you were around when I was talking a couple of weeks ago about inflammation. So the reason that we need repair is we need inflammation to have repair. You can't have one without the other. You need inflammation. Inflammation triggers the process of macrophages and phagocytes coming in to clear away the debris. And along the way, they also then trigger this process called angiogenesis, which triggers more cellular activity. Now, you can't control the cellular activity. If you've got cellular activity which is creating repair, you can't voluntarily switch it off. You don't know when it's going to switch off or switch on. So when you've got inflammation that's caused, say, by something like smoking or respiratory disease, then you're going to still have the same principle, that you're still trying to repair it, but you're going to end up with cellular activity. And so this is clearly now cellular activity that's been laid down. Yeah. So I see I appear to have an empty slide, which is nice. Where are we? Okay. So what we'll do is we'll just have a little look at a video that I've got another one here, which is the video of some adhesions. Okay. And you'll see what this looks like as you start to see the breath coming in. So I'm just going to pop this into there. So look carefully on this edge, just on here, as we start to get around into here, as we start to inflate those lungs, you'll start to see that this lobe here, sort of between these lobes here, between this one, can't quite keep it still, but this area here, okay, I'm just moving my nose into that. This area here, can you see this? There we go. You see those little adhesions? You can see how the surfaces aren't opening up. So again, the reason you have the lobes is because those lobes need to slide around. And you can see here, look, that's a little adhesion. That's not going on there. I have to get a scalpel or something into there. And there's quite a lot of buildup in between those lungs, in between those lobes of the lung, that are saying this is not moving around. Now, there's nothing you can do with that in terms of, once you've got that there, I would suggest that it's going to be hard to get rid of it. But certainly at this stage in the game, you're pretty stuck down. The lungs still are pretty healthy. There's still a lot of healthiness and good color to the lungs. There's a lot of pinkness in there, but you can again see just that little stickiness in there, how it's stuck. And you'll see this further down as well. There we go. Let's try to open that up there. And there's a creating space. So we could get our fingers in there and get that opened up. And you can also see it down here. I mean, if you look down on the edge here, you can also see where the lower lobe, right lobe of the lung is stuck, and it's not moving around on top of the diaphragm. That's a little bit more serious, I would suspect, in that instance. I wouldn't be able to tell you for sure, but I would suspect there's a little bit more seriousness to this when it can't move around on top of the diaphragm. So the entire surface, there we go, you can see it here, look. See how it's stuck in there? And there should be no sticking at all. There's no, like in the viscera, there's some little tendons. You get these sort of more holding points into the abdomen. But really, the whole of the lung should be able to be held, lifted up, and taken out without any cutting or any pulling. Obviously, where it's coming out from the heart, you would see that. But there should be no, there we go, that's an adhesion of the lung to the diaphragm. Yeah. So we shouldn't see that. We shouldn't see that at all. So the diaphragm, we'll come to the diaphragm shortly, but the diaphragm has a layer of fascia across the top of it, but it's also covered in this parietal pleura. So the whole of the parietal pleura overlaps the diaphragm, and then there's a layer of fascia that covers the diaphragm, then there's a muscle of the diaphragm, and then there's a layer of fascia on the inside of the diaphragm, and then there's the parietal peritoneum comes up to that as well. But this is lovely when you see this. I mean, it's obviously not lovely to see it, but you see these adhesions down here, the stickiness that's in here, and there's like this webbing in there. It's amazing. But this is all connective tissue again, so it's going to be generated by the same structures that would generate connective tissue otherwise, and they're going to be constructed according to the need, which is put down probably in this instance inflammation. I don't know what's caused this. How are we going with that? Yeah. So how much do I think lack of hydration plays a part in adhesion? None in this instance. I don't think hydration as such, in terms of drinking water, has any role to play at all. Simply because the tissues are called serous tissues, and they're producing their own fluids, and so they'll produce those tissues, those fluids, whether you drink water or not, and they'll just take them from other parts. So obviously we need to drink water, a usual amount, but hydration is about the movement of it. Lack of movement is the key because of inflammation. The question, what is abdominal breathing if the lungs are so high? Well, how about, we'll talk about that later on. So there we go. So when we exercise and build strength in the lungs, does that cause cell repair as with other muscles? It's hard to say. I mean, the bottom line is don't get yourself to that point in the first place. This goes back to what I was saying at the beginning, is that ideally our ability to, if we're going to get dragged down by a respiratory illness, the chances of us getting dragged down by respiratory illness are higher if we're not fitter in the first place. And so the object, wherever possible, is to get fitter and stay fitter wherever possible. And the business about where we should be breathing into, our diaphragm, our abdomen, our back, or anything like that, is just a bit silly. So there's no such thing as diaphragmatic breathing or abdominal breathing, and we'll come to that in a minute. It's just, So by the way, just before we start, next week we are going to have a go at the psoas. So we're going to pour a bit of cold water on that. So get your registrations in for that, because I'm looking forward to that. I've been looking forward to that for a little while. Gorinda says, to what extent do you think the breathing exercise could reduce the impact of the adhesions and improve the movement of the lungs? Even if you're already stuck down, even if it's like anything else that's stuck down, if I've got some surgery and my shoulder's not going to move again, then I need to get my shoulder, the rest of me moving, so the rest of me doesn't impact. I'm generally not going to use 100% of my lung capacity anyway, so the more function I can get into what's left of my lung, the better. Can lungs attach the diaphragm? Have a little look. We just looked at that video. That's exactly what they just did do. They attached the diaphragm. They didn't attach the diaphragm themselves, but they attached to the pleura. The parietal pleura was adhering to the visceral pleura of the lungs and holding it down. But lungs should not be attached in any way, shape or form to the lungs. They shouldn't be attached to anything apart from the hilum, which is where they're attached to the blood supply going in and out. Let's carry on with our our slides here again and see what we've got to. It's always a bit of a mystery. And what we're going to do from here on, we're just going to jump a little bit. I seem to have just, there we go. Let's go a couple of rogue ones into there. They've, okay, where are we? So we're going to have a little look now at the lymphatics, and I've put some notes into the chat box here. So I'm going to share the files that I've got here as a PDF. There's a share there. So you should be getting those just about now. And there's a few thoughts that I've had in relation to them, and they talk about the lymphatic system. So we're just going to go through this pretty quickly. The reason that I'm talking about the lymphatic system in this instance is because they are the public transport system. So for those of you not living in Great Britain or living in London, then this is Transport for London. This is your Oyster card you don't use anymore. The tube train, the bus stop, is Transport for London. And the lymphatic system is kind of like the public transport system for our immune system. It's a pretty important bit of kit. The blood supply has a big pump. It runs itself around, and it can get pushed around the system. And unfortunately, what we have in terms of the lymphatic system, it relies on muscular contraction. So the thing about the lymphatic system is it consists of lymphatic fluid, and I've put this all in the notes, lymphatic tissue, and it functions to drain excess fluid, but it also hydrates the blood, and it initiates an immune response against disease. So this is really what we're dealing with. So there's a whole load of stuff that we have to consider in relation to the lymphatic system. The immune system response is that it's transporting lymphocytes and transporting dietary lipids as well. We'll talk about that briefly, absorbed by the gut. So fats. So the lymphatic system is also absorbing your fats. And we'll talk a lot more about that next week when we come back to the psoas and what I think is going on with it and so on and so forth. So pretty much the whole body is reliant on, as well as we talk about hydration, but the lymphatic system is the root, the basis for our hydration. We've got to get this hydration, this fluid movement, this interstitial fluid and movement going through it. Everywhere we've got veins and arteries, we've got the lymphatic vessels, accompanying them all the way around the body. And you've got about 600 lymph nodes, these sort of little bean-shaped glands around there. The drainage is via the thoracic duct. So the thoracic duct, we go on to our next little slide here, is this little fella in here. Now, I couldn't really see it on our Netta friend, and it's hard to see in, I thought I zoomed into him. Where did I zoom into him? I thought I did. Yeah, so this is our thoracic duct. We'll go back. I'll come back to this in a minute. But this in here, if I just put the marker in here, this little green fella right around there. Okay, let's clear that and put a better color onto it. So we'll kind of another color, pick a color. And there is our little green fellow, and you can see him into here. But that's our thoracic duct. So our thoracic duct drains into the subclavian vein, just underneath the clavicle, and then straight into the heart. So all our lipids, our fats, don't go into the digestive system. They get mixed with the lymph, and they get pushed up through the thoracic duct, and they start on the right side, get pushed across the top, drained into here, and the right lymphatic duct drains the right side of the body. It's a lot shorter, and it's draining the head and the right arm. Let me clear that off. If I just draw my little circle down around here, this is the base where I think everything is going on. This is an area of enormous interest to me, and we will talk a little bit about that tonight, and we'll talk a lot more about that next week. But essentially what we're looking at is we're looking at an enormous functional area, which is involving the psoas, the quadratus lumborum. It's involving the crura of the diaphragm, and it's effectively, you can see this sort of incredible star that's going on in here, right in the center of the body. And so this is where I think we have a lot of function going on, and we'll be talking about that when it comes to psoas. All these little green things that you can see in here, these are all lymph nodes, so these are all lymph nodes. The thing that you can see in the thoracic cavity, of course, is that you've got a lot of lymph nodes in the thoracic cavity, both front and back. You'll see that in the graded chart in a second. So that means that your breath is driving your lymph. So lymph nodes predominantly are congregated a lot more where there is functional movement, and of course, breath 15, 20,000 times a day. Around the armpits, around the arms, again, lots of movement through the shoulders, around the groin, backs of the legs, into the head and the neck. So these are all structures that are moving our lymphatic systems around, and at the same time helping us with our breath. How are we doing? Diaphragmatic and abdominal breathing is more anecdotal. Yes, I think that really we've got this this idea of where we breathe. I think the thing is breathe regularly, and if increase your rate of breath as much as anything else. The idea of diaphragmatic breathing, or somebody saying you should breathe like this or you should breathe like that, it's like, don't tell me where to breathe, I'm still breathing. So I don't buy into any of that kind of stuff, really, as far as that's concerned. When we go back to the idea of our lymphatic system again, and I'll put this in the notes here as well, the function of the upper body in respiration is twofold. That the head and neck, if you think about driving lymphatic systems, the movement of the upper body and the limbs drives the lymph both directly and muscular contraction, and through increased respiration. And secondly, that we know that a lack of movement creates lack of ability to move. If you don't move, you stop being able to move. And so if you then get stiff and you get tense, if you then had an injury from that, then your injury would be more severe, your recovery time would take longer. So why should things like viruses and circulatory issues be any different? Just because we're fighting an immune system, or immune system illness, or respiratory system illness, the fitness of our ability to do that is entirely dependent on what we've done prior to this. So the virus doesn't come along and wipe you out simply because you're fit and healthy and strong. It's very rare that it does that. It wipes you out or hurts you or damages you simply because you have a series of other things, and that is every single issue that we have in this is showing us that. Again, I'm not invalidating anybody's illness or experience, and I know there will always be outliers. There will always be people that have got sick and young people, but generally speaking, it is the people that have underlying health conditions, that are older, that have other stuff going on. So age is a factor, but fitness is more of a factor. Prevention for this starts now. It's what I say in these notes, that 20 years ago is the best time to start a tree. Okay. So Matt says, I don't encourage a form of breathing that utilizes fewer upper chest and neck accessory muscles as taught in breathing pattern disorders aspects. I think when you have specific issues, then yeah, by all means. But generally speaking, I think we can talk about posture. We can talk about head forward posture, which is the worst. Let's face it, And I think I'm not saying don't teach awareness of breath. I am saying the whole thing about you should diaphragmatic breathe through your diaphragm or through your abdomen, A, is physiologically unsound and biologically implausible, and B, it's just, well, I refer you to the second one. Absolutely be aware of your breathing, the pause in the breath. There's lots of different things we can do. There's a great exercise that I give, which is to count out loud, to take a big deep breath in and count out loud. So take a big deep breath in and go 1, 2, 3, 4, 5, 6, 7, 8, and see how far you can get. And the more you do it, the better your breath becomes. So gravity is not gravity and lymphatic drainage are not that necessarily conjoined. Lymph is not a gravitational force. Lymph is a sucking force because it goes upwards. So lymph drains upwards. It doesn't drain downwards. Lymph drain is mashes. I've had people that swear by it, and I've had clients that have manual lymph drainage at hospices and stuff for issues. Again, if they've had mastectomies and so on and so forth, then you are helping that movement of that lymphatic drainage where the lymph nodes have been removed. So head and neck cancers state otherwise. Okay, well, David, I'm going to tell you that the thoracic duct is where your lymph drains into, and it starts here and it moves upwards through your thoracic duct and drains into your subclavian vein, into your heart from there. So that's the physiology of it. So yeah. So, but lymph isn't a gravitational force as such, because it drains upwards. So, if it was going to drain, if lymph was going to drain as far as gravity is concerned, we'd have to work out where it was going to drain to. Pelvic floor fascia. Yes, we'll get to that very shortly when we get to the rest of the diaphragm. So we will get there. Okay. So where are we? So let's have a look at the next one. We're going to come into here again. So in this area I've already mentioned, we've had a little look at that. So zoomed up into here. So hopefully this is a little bit clearer. This is the thoracic duct. This is the subclavian vein, internal jugular. You can't see this is the left thoracic duct. It's about 35 centimeters long, and it starts from down here. So this doesn't start, but this is our big drainage area for our this is called the cisterna chyli, and this is where it picks up the chylomicrons, which are the micro parts of the lipids, the fats, if you like. It mixes them with lymph. It's therefore called chyle, and it gets pushed up through the cisterna chyli upwards through the thoracic duct and then into this little fella here, which is the thoracic duct to here, and then you get that circulation aspect going on from there. So that's where we drain into. Little idea of where our lymph nodes are going through here. So again, we can see that circulatory aspect of lymph nodes. A lot of these are coming from Netta before we get into any dissection stuff from there. And this is just your lymphatic vessels. I've got this put into you there. so you can start to see where a little bit where this stuff's coming from and where all your specific lymphatic vessels are. So that's in the notes as well, so you've got that. So this is kind of like a little sort of skeletonized series of pictures, and I've just left in here the common hepatic artery to give you the idea of what we're looking at. Otherwise, it starts to become a little bit tricky to get a good idea of what we're looking at. So, if you imagine this is the spleen. This is the spleen here. That's the spleen there. This is the heart up in here. So the liver would be sort of around here, and this is your abdominal aorta and your inferior vena cava. And so the lymph nodes that are sort of stuck in the space of that. Another little diagram, and you can see how busy this sort of mid area where the diaphragm, the tails of the diaphragm are coming down to here. Psoas is coming up, QL is coming up, and you've got this big concentration of lymph nodes in the middle of this body here. And if we take it all away, there we go. Isn't that beautiful? So you can start to see a little bit how busy these lymph nodes are in the middle of around the spine. So spinal movement, diaphragmatic movement, and visceral movement is all going to be very key into here as well. Okay, let's have a little diaphragm. We'll also have a little look at a video while we're here. So I wanted to show you the connection to the lung to the diaphragm. So this is going to show you a little bit. Okay. All right, so hopefully you can see that now. Just going to pause that a second so you can orientate yourselves, or I can orientate you. What you're looking at here is you're looking at the parietal pleura. This is the inside, so we've got some superficial fascia around the outside here. You can see a little bit of lung in here. I'll clear it away when I'm done, don't worry. And you've got the tails of the diaphragm here. What this white stuff is in here is the parietal peritoneum. That's the sac that's sitting around the outside of the viscera, and which is going to continue downwards and sort of hold all the viscera and become the sort of the ceiling of the pelvic floor, if you like. So that's where you're going to go down into this, and the diaphragm is going to blend. The fibers of the diaphragm, the fascia of the diaphragm is going to blend into the transverse abdominis. Let me clear that away again. You can see the little lobes of the lung in here, and this is the edge of that sort of thickened edge, if you like, of the parietal pleura, and this is the rib here. This is our 12th rib, and this is sort of the inside of the rib. It's slightly broken away. So what I'm doing is I'm inflating the lung from the top, much like we did for the rest of the body. It's a bit tricky to see what's going on, but what you're seeing is a downward pressure. So up underneath into this area where my finger's pointing, the liver would be sitting into here. And so the movement downwards would be creating fluid pressure and air pressure onto the abdominal cavity as well. So the separation between thoracic and abdominals is minuscule. It's barely a screen. It's barely a separated screen. And it's very easy to get into that space. We go, this is thoracic, this is abdominal, but it just doesn't make any sense because, well, what's the separation? The separation is nominal. The separation is not. It's important from a physiological perspective, but functionally we are, and from movement perspective, they are separated by a very, very thin screen. And functionally, it's very, very clear that the diaphragm is going to have an effect on abdominal and visceral function. Okay, how are we doing? Just going to check in a little bit of a bit of halfway house. Do I think of the restriction of bras in the area of the thoracic duct? I tend not to wear one. And the same thing for vagal tone. It's one of those areas that is controversial, and the evidence is poor. And I'm careful not to get too much into the idea of things like bras, but it's a tricky one, isn't it? If you strap yourself into something and you leave it on for 14 hours a day and you feel it's restricting and it's putting your shoulders down, then it's reasonable to suspect that you're going to end up with some kind of potential restriction through that. So there we go. I think there was a study that was done a few years ago that said my ex-mother-in-law used to own a lingerie shop, and she was taught how to measure women, and apparently something like 90% of women wear the wrong size bra. So I can imagine that, again, there's some papers been done on shoulder restrictions and neck restrictions. Lymphatic movement, I don't know whether that's been done. Let's have a little look, go back to our slides again. So looking at our diaphragm, the idea of the diaphragm being a sort of a separate sheet of muscle is a little bit of a misnomer. So in here we can see the diaphragm being indicated, and it tends to be drawn in this way. That's quite common. But what I want to draw your attention to here, in this perspective here, is what we start to see coming up in terms of our other muscular structures. So let me just get myself a pen. What do we got? Here we go. So we got psoas minor coming up onto it, and we've got quadratus lumborum coming up onto it, and we've got the tails of the diaphragm. The diaphragm coming all the way down with fascia of it and the tendon of it blending as far down as to L4, and we've got this diaphragmatic hiatus, which is where we've got our esophagus coming through here as well. So this is where we end up with things like hiatus hernia, where the stomach can push up into the mediastinal space. And I've opened people up before, and there's a stomach there, and there's nothing down into this cavity here. So all of this area here is a big dome, and we're going to look at some dissection picture of this as we get to that. Going back to our picture from the back again. What we can again see is this domey shape, just reminding us it's quite a useful thing to see this again, seeing our perspective. Here's our lungs, there's the shape of our lungs, but here's our space, and then tucked right up underneath that is most of our visceral organs, our stomach, our spleen, the liver is up underneath there, gallbladder is up underneath there, duodenum's right up underneath there, and the major part of our digestive process is sort of tucked almost up underneath the lungs there, and certainly the fascia of it as well. And there's lots of variation to it, so you can open an abdomen up and nothing's where it should be. In fact, I would say that probably happens most of the time, that it's not quite where there is nobody's quite the same. I really like this little cut through from Netter. It's not very practical, as a lot of Netters are, but it's kind of cute. Just to show again, just to give you the idea of how thin, how tiny this connection is that we have that goes across the top. Look at the diaphragm. Here's our diaphragm, and fair play to him. Netter does show the layers there. I'll take it off. He does show the layers of the diaphragm in terms of the pleura. So we can see the lungs sitting across the three lobes on the right and the two lobes on the left. So this is a coronal slice through from sort of down the middle, and you can see that the heart is into here and how that sits across there, and you can get this idea of the liver, and the stomach is into this space into here. And if I just clear this away, you can see how faithful he's been. So you've got the pleura, if you like. Okay, this is the pleura of the parietal pleura of the thorax. You've got the diaphragm, and then you've got the sort of fascia of the diaphragm and the parietal peritoneum coming up underneath the diaphragm there. Kind of cool. Again, just another little idea in terms of what's going on there. So this is a very cool picture, and it's something that it requires a bit of work to do, and it's kind of fun to do. But this was a great example, and we've got some really nice bits of tissue here. But what you can see here, I can't zoom in, unfortunately, but what you can see here is you can see what I'm talking about is that the diaphragm is all these fibers. These are the fibers of the diaphragm coming down through here. And what you've got through here is the muscle, the transverse abdominis. And transverse abdominis is going this way, and the diaphragm is coming down to meet it this way. And there's a continuity of the external fascia of the transverse abdominis blending in with the fascia of the diaphragm. And so this now creates this whole sac. So remember we went back before and we saw that Netter picture. And that Netter picture, if I just change my color here as well. And we saw that Netter picture. And the Netter picture sort of was this cross section from here. And I was saying to you that once, or it might have been the primal pictures one, But the whole of this is one unit. The whole of this is one bit of tissue. Now, it has to be separated and organized. Otherwise, you're going to end up with changes in fluids and changes of pressure. But essentially, it's one unit, one visceral unit, all intact. And you could blow, these lungs would still be intact. So we could still put a little, we got a little hole there. We could put the ambi bag into there, and we could inflate these lungs, and these lungs would inflate beautifully. And they do that. If you want to talk about the pelvic floor, well, this is the bladder. Here's the bladder. Now, we talk about intraperitoneal and retroperitoneal. And so the peritoneal tissues are organs going in and out. What's holding it in place is our transversalis fascia, holding that in place, and the parietal peritoneum stuck in that sac. And then you've got pretty much the whole of the structure of what you would call the pelvic floor is down there, but that's a muscular structure rather than it being a fascial structure. I'm not a great fan of the idea of a floor as such for the pelvis. The pelvic diaphragm would be more accurate. But what you have got is you have got a lot of cutting that goes on to do this dissection. So we're having to cut all the way around through all the ligaments of the rectouterine ligament, all the tissues that are holding this in place, all the way through the bladder, all the fascia that's coming down from the abdomen and blending over the pubis and down into the lower limb, things like the sartorius and so on and so forth. If I showed you the posterior view of it, you'd also still see a fair bit of muscular structure into there, great. There we go. You can probably see me now. And some muscular structures about there, and of course, all our blood supply is in here as well. So, kind of a cool picture there. Any questions about that, very quickly? Do the floating ribs influence the movement of the diaphragm? I think everything influences the movement of the diaphragm because it's attached to it. So the thing is that particularly on the lower aspect of the rib cage, you've got more attachment. You come down to these last 3 or 4 ribs, and that, particularly the last 2, and they are very much attached to, stuck onto the diaphragm. You're peeling rib cage away from diaphragm on the last 2 there, and so it's pinned down. A lot more is pinned down than we think. This stuff isn't moving around. It's not floating. There's this idea that this stuff floats. It doesn't. In order to get this tissue, this bag off here, this is absolutely stuck fast onto the spine. It's pinned. Every single bit of it is stuck and pinned very, very heavily onto the spine, onto the pelvis, onto the sacrum. It doesn't just lift away and float off. It's not floating. It's held there, and it's held there intact. And once you get into the viscera, all the viscera, you don't just cut open a bag and your guts fall out. They don't. They are held in place, and they're held in place very, very firmly. You got a baby up there. What part do these structures play in our core? There isn't a core. The whole concept of a core is just ludicrous. And the idea of a core, I don't know where would you start with a core? Come back next week and we look at the size. We're going to search see if we can find a core, and I want to try and see if we can look at this core. But the whole idea of core stability, core anything, kill me. So. Let's go. It should be fun next week. We should. I'm glad we're in lockdown, actually. Otherwise, I'd get bricks thrown through my window. Duodenum. What happens when there is a prolapse? A prolapse of what? You can have lots of prolapses. So you can get a hiatus hernia. That's kind of a prolapse, where the actual esophagus and muscle gets weakened. The esophageal muscle hiatus gets weakened. The stomach gets pushed up. If there's a hiatus, a hernia in the femoral area, whether it's an inguinal hernia or a femoral hernia, you get a weakness in the bag because those testicles, if you look at these testicles here, these are testicles, these are coming up, and they end up coming through a little space into this bag, and they come around and drop through the prostate and down through this side. So this little ring that you have where the testicles go through can often become weak. The inguinal ring weak, and you can get the viscera and the intestines get poked out through there. So the bladder, a prolapsed bladder, or a prolapsed bladder on a woman, or a prolapsed vagina, it will just drop down through the vagina, and it's pretty unpleasant, and it gets pushed up with a mesh. And there's been some problems with the meshes over the years. We're going to crack on because so much to do. come back to any questions. And so we're looking on the outside here. So this is some of the influences that we might have around the outside. We're going to sort of pop through these a little bit. Going back up to, I wanted to just show you what we have to get through in order to get to this area. You've got pectoralis major, and this is the rectus sheath up and down here. So this outside layer of the rectus sheath, and then you've got these external oblique, internal oblique, and transversalis goes underneath all those. But you have to get through external oblique and internal oblique to get to this next stage that we're looking at. And you have to go through the internal structures again, pec minor. And so you can start to see a little bit where we're getting into. So this is the transverse abdominis down into here. The rectus sheath sort of is going to go underneath the transverse abdominis, is going to go underneath that. But you can start to lift up this rib cage through here, around through the xiphisternum. You get the idea of what you're going to see when you come underneath it. And as we lift up, so this is the rib cage. This is transversalis, this is transverse abdominis, this is the rectus sheath into here. And then we start to lift up the rib cage. This is the xiphisternum here. And what we've done is run the scalpel up against the inside of the rib cage here, rather than actually cutting it, which would be a classical dissection cut to cut along the rib cage. Instead of doing that along here, we're coming up, keeping the blade flat, coming up underneath the rib cage, and we're separating this out. And that allows that diaphragm to remain intact. Again, you won't see this in a lab normally, you know, it's thanks to Gil Headley that I learned all this stuff to do. I've varied a few things, but pretty much it's down to Gil that this is his model and what he's found. So by cutting through here, we create a space around to allow the whole of that viscera to become clear and get cleared out. A little bit more light on this one now. We can start to see again, we can start to see this muscular structure that's into here. And we see the rib cage. This is inside the thoracic cavity now. And if you were asking before about the ribs, you can get the idea of how the lower ribs will be blending in. There'll be a lot of thickening, a sort of a confluence, if you like, of the two structures on the inside of that rib cage. If you remember to clear that, clear my felt tips away. Let's pick another color. So this is looking down now. So if you imagine we've taken the heart out, heart's come out, and the lungs are out, and you can look down on the diaphragm, and a light's being shone up underneath the diaphragm. So from down below, from the abdominal cavity, and you can see how thin this is. And this is what I was talking about the idea of diaphragmatic breathing or abdominal breathing. It just when you see something as thin as this, and the job is basically to flatten and create space in the thorax, it doesn't seem to make a huge amount of sense. We're talking more about the posture or the position of the upper body rather than necessarily the function of the diaphragm in relation to its breath, as far as I could see. And this is from the other end again. Here you can again see we go. So this is from the top down, and then this is from the bottom up. So we can see again a light being shone through here. So this is the left side of the body, this is the right side of the body, and we can see the top of the viscera, if you like, into here. The liver's been taken away. Is there any particular stretches or sleeping positions to help create more space? And what problems with bladder mesh TVs are there in relation to fascia? Well, it's scaring out. What is the core? I'm still good. Cool. Yeah. The meshes have been a problem because again the trouble is you can't determine what the scarring is going to be. So if you put mesh into something which holds, then you pin the fascia of the bladder to the fascia of the back of the sacrum, you can't determine what. Of course, you've got an inflammatory process as far as your healing is concerned, but you can't turn that on and turn that off. And so sometimes you get an over thickening or over tightening. You just don't know. It's very, very hard to work. Is the diaphragm contractile? Absolutely, because if it wasn't, you wouldn't breathe. So in order for you to what happens as far as your breathing out is concerned is you contract your diaphragm. You're breathing in, you contract your diaphragm flattens, and the external pressure, the barometric pressure in the room, now has to equal to a concentration gradient, and air rushes in. Yeah, in order for you to breathe out, okay, if you breathe out, you relax, your diaphragm now stops contracting, it presses the air out, and you breathe out. All right. So breathing is kind of passive. It's not actually something that happens as far as your lungs. You're not using your lungs to breathe. You're using your diaphragm to create space in the thoracic cavity, which is why if you go higher up, what you find is that the barometric pressure between your lungs and your outside is less. So the higher you go, altitude you go, barometric pressure is lighter. So therefore you have to breathe more. You have to work harder to get your breath in. This is the problem that you have with respiratory illness. You have COPD, chronic obstructive pulmonary disease, and the lungs are elastic. They have elastic recourse. So as you breathe in, your lungs fill up, and then in order for your lungs to as well as to breathe out, your diaphragm then comes up, and you contract your diaphragm to pull it down. You let it go, you'll breathe out, but your lungs also have elastic properties and they recoil. So the elastic recoil of your lungs is a really important function of your breath. In COPD or smoking, or where you've got inflammatory diseases, what's happened is that you've ended up with the elastic properties have decreased, the elastase has increased, the elastic properties have deteriorated, and you don't have that elastic recoil. So what now needs to happen is you now need to use all your accessory muscles, a whole bunch more, in order to be able to get that breath. It's a little bit like the stretch that we've been talking about a few weeks ago with the Ehlers-Danlos and the hypermobility syndromes, where you're trying to find that stretch response, and you're working really, really hard to do it, and it's very, very tiring. So, the light diaphragmatic breathing, you're breathing anyway. So, it's about how much space you get and the accessory muscles that you use. Okay. Does the diaphragm behave like a lymphatic sponge? No, I don't think it does. The diaphragm is basically creating space in diaphragm by relaxing and contracting, but it's also at the same time, as it's relaxing and contracting, it's also moving and massaging your viscera and therefore your big blood organs like your liver. You've got to bear in mind that there's pressure in here. This is under pressure. There's under a lot of thoracic pressure. So yes, the diaphragm is contracted. So with abdominal muscles connected with the diaphragm, well, they're all connected with the diaphragm, whether they're external, internal, or around the back. But transversalis, don't forget, goes all the way around the outside. But the actual connection with the diaphragm, fascially, is going to be the transversalis. I'd say your intercostals are going to give that as well. Let's go back to this. Still got loads to get through. So just if we go back to that there now, and again, I put this picture in again secondary so you can see it. You can see the thinness of that diaphragm and what that diaphragm is going to do when it contracts, okay, and it pulls itself down. And then you get this space, there it goes, and you get the space, the diaphragm drops down. But you can see how much space there will be in this area around here because don't forget, this is all rib cage coming up into here. So how much space isn't lung? As the lung expands and wraps itself around that diaphragm, it's in direct contact with the liver and all the other organs that are sitting up underneath the diaphragm. And we showed that picture of Netta, how thin the diaphragm was and how big the organs were. So the idea of this thoracic space and abdominal space is something that I think probably is one of the most harmful distinctions that we've made in anatomy over the last 200 years. This is the thorax, this is the abdomen. We've generated this idea where we've just got literally a sheet hanging down the middle of the room. You wouldn't go into a house and go, it's a 4-bedroom house, and you've got 4 sheets hanging down the middle of a room and go, yeah, that's okay. But we do this within our sheets within the body, and I think it's very detrimental. And I put this in my notes here as well, that the mental separation of these two areas in anatomy is probably one of the most harmful of all the many separations that exist. By separating their functions, we can attach words, surgery, breathing techniques, manual therapy approaches, and all kinds of other ideas, and direct them to the space that we choose. So visceral manipulation, abdominal breathing versus diaphragmatic breathing, and so forth. The effects of one on the other is inescapable and immense, and whilst clinically directed reasoning towards diagnosis is needed. If you've got a blockage somewhere, you need to identify. The dependence of those two on each other should not be underestimated or undervalued. And I think, this is the trouble, is that we've let go of a lot of these connections, and this is what I'm trying to do in the dissection stuff, is to try and get this connection back. You know, stop it. If we're going to do this as manual therapists, we've got to stop thinking anatomically along the lines that we're teaching our medics. It's not going to work for us. Okay. This is a project from Gary. Gary, so put your hand up, Gary, if you're here. With asthma, there is an inflammatory and histamine response, but what does this do? No, asthma. In asthma, there isn't necessarily a histaminic response or a inflammatory response. That's the trouble. Is that this is why if it was inflammatory, you could use an anti-inflammatory. But what you do is you use steroids, and that's different. So, you know, there isn't necessarily with asthma. It could be diaphragmatic, and we can stop an asthma attack. And I'm going to show you how to do that today. What does this do to either diaphragm or the lungs? Elastic recall that's affected is within the lungs. Asthma has got nothing to do with the lungs. Asthma is not a lung condition. Asthma is a bronchial condition. It's a spasm of the bronchioles that could be all kinds of things. It could be environmental. It could be it could be stress related and various other things. But actually, lungs are neither here nor there. You get somebody that's got chronic asthma and you open them up and the chest is absolutely clear as a bell. But it's the mucus that you end up with, or the blockage that you end up with as a result of your steroids, and that's why you have to have a steroid to stop the mucus, and the bronchial dilators open up, mucus comes on, the steroid stops that. So here's Gary. So Gary Carter was on the team that did this, and so there's 2 or 3 pictures here. It's a great little dissection here, and what you're looking at is quite interesting, because you've got a whole bunch of stuff in here. You've got the diaphragm at the top, and for those of you that were talking about the pelvic floor, what you've also got is you've got the beginning or the edge of gluteus maximus down into here as well. And in a minute you'll see this connected down to the femur as well. So good on you, Gary. This was something that I know you were very keen on doing, and it came out really, really well. And I was looking for something that was a little bit unusual as far as these pictures. It takes me days to put these things together. You have no idea. It's quite stressful. And let's have a little look at the next. There's a couple here. Can we have a little see that femur connecting down through here? So what have we got? I think we took piriformis up into here as well. Is that piriformis, Gary? I can't exactly remember what we did, but but the whole of this tissue, it wasn't hard to sort of take it apart in terms of one bit of tissue, because the whole idea was that, there we go. You can see that through the femur through here, through back edge of I think gluteus minimus that was, and gluteus medius on the opposite side, and you've still got QL attached into that. So you can start to see how things like even extension or rotation of the hips are going to have a torsional effect through the pelvis. So I don't think this is psoas in here, because it looks too far back. It looks like it's gone posteriorly. No, you might not, Gary. So yeah, I think it's actually gluteus minimus, if anything. But it's hard to remember exactly what we did. We need to write these things down better. It was psoas to diaphragm. Yeah, okay. What's psoas to diaphragm? I'll give you that. So again, we're starting to see movement, but the problem that we have is that we've extrapolated something and we've taken it into isolation. So be careful of models that we make. This is very, very cool, and it shows you that connection. But we wanted to show it. It's like anything else. The psoas is definitely on this side. But again, it's like anatomy trains. They don't exist. They're not there. They're not real. But you can make them be there if you so wish. I just wanted to just quickly go back to this question here about the difficulty breathing could be caused by the sticky fascia holding down the nose, the lungs. No, I don't want to call it fascia. I want to call it connective tissue, because I'm not going to say it's fascia, because that would assume that it's collagen rather than elastin or any other kind of tissue. So, but it is connective tissue of some description. It's probably going to be collagenous based. The difficulty breathing could be that, but that's the inflammatory response from disease, not necessarily asthma. This is Suzanne's question. Sticky fascia under the nose and lungs is caused by an inflammatory process. Yes, I'm going to say yes. It could also be caused by treatment, because could be caused by steroids, could be caused by lack of movement, it could be caused by somebody sitting in one place for a very length of time. I'm guessing here. I don't exactly know. It's not one of those things that's massively well documented. It could be caused by surgery. So there's lots of reasons that could go on. Anyway, yeah, very cool picture, very cool structure. And what we've got here also now coming across is you've got the diaphragm being peeled back, and this is the parietal peritoneum, and you can just see that there is still a bit of fascia of the diaphragm. So this is the peeling back of the diaphragm from over the top of the visceral sac. So this would be the liver underneath here, and I'm always very interested in how thin I can get a scalpel, and how much I can do in terms of taking something away and still having a bit of tissue. To all intents and purposes, these are stuck together. I mean, these are not separate structures. They're not gliding surfaces. They're not sliding surfaces. These are now fairly dry, and so they can be peeled. But in vivo and in life, these are surfaces which have space to allow interstitial fluid to move through them, but from a functional perspective, they have little or no relevance in terms of what we are thinking about. We're not saying here is a surface sliding around on top of another surface. I do want to make that very, very clear. Can you explain why tipping a COVID patient on their front works in these cases? Again, this would be gravitational, getting any fluid. That's the thing about any respiratory illness, and don't forget that COVID is a version of SARS, which is sudden acute respiratory syndrome, is that you fill up with fluid. And so anything we can do is called postural drainage. And so you're going to get patients onto their front, going to move them forwards, you're going to give them movement, and you're going to increase the movement, help them to expectorate and get that stuff up. So yeah, and get that sputum up. I was always advised never drink a cup of sputum, it all goes down one up. So again, we're going to see, so we can see the sternum here attaching to this. The sternum, this is the underside of the sternum, a little bit more of a line. This is the inside of the liver again, so we can start to see the falciform ligament of the liver coming up into here. And this is the edge of the lungs, just again to show you how much attachment there is from the front of the sternum, how stuck that is to there as well. It should be stuck. That should be, because it's creating the space. Don't forget, again, the sternum is the attachment site for that parietal pleura that's going to separate one lung from the next. You can collapse a lung, one lung can go down and have no problem. How many bodies have you dissected did not have adhesions in the lungs? I'd say most of them don't. Hard to say. A lot of them don't. I'd say most of them are fairly healthy and moving around. The ones that you get that are really severe, really stuck, you get some of those, and then you get the odd one there's an odd one or two, which could be just a little bit of a bit of small chest infection, or a bit of smoking, or for all we know, it could have even been a broken rib 20 years ago. That could be something else. It's hard to say. I really couldn't give you an answer to that. Malmo ventilators will ventilate uppermost, and there's more lung posteriorly, so prone. So yeah, okay. Which abdominal muscle is connected with the diaphragm? I told you that. You keep asking that, Ali. You have to bring me some dates. Accessory structures. So as well as the diaphragm that we have, which is moving up and down, we have a whole load of stuff about accessory structures, which are going to give us both the position and the space within our chest. There wasn't one more video I wanted to show you as well, which was, going back to this, I just want to show you this. We had this dissection from here. I'm just going to show you a little bit of this video. Here we go. So this is just to show you, the space, a little bit of the section I was doing here, and how paper thin, how wafer thin that parietal peritoneum is. And I'm just really carefully peeling this away, and you can start to see that sort of little fluffiness you get, and you see there's got a few holes already appeared in it up in here, look, and it's easy to get that. And I was just started with a scalpel and just started to to slowly peel away. And Anna and myself had a little go at a little blood vessel in through here as well. All these tissues are massively innervated as well. You've got a lot of blood vessel coming into it. You can see the muscle here of the diaphragm. So this is the fascia of the diaphragm on the surface here, and this is the parietal peritoneum, and this is this sort of fuzzy space in here. But you can see the muscle. So there is a fascia of the diaphragm here, and then there is also the parietal peritoneum. Again, to all intents and purposes, they are one and the same. There is no functional separation. This is just me being a bit geeky with a little number 11 blade here that you can see, and a bit of time on my hands. So again, a little bit more of a carry on. There we go, and we've got it off there. So yeah, you can tell it's my stuff. I carry my kit with me. Anything that's got a yellow bit of nail varnish on, that's my bit of kit. So I'm always carrying my kit around, scalpel blades and what have you. There you go. You see it peeling away from there. That's it. It was just more to show that we could do it more than anything else. But even when you've got a separation, it tells you that fluid is going to move through that space. Let's go back to our slides. Okay. And I'm going to turn this whiteboard off. Where's my slides gone? Where's my slides? Next. Okay, there we have it. Okay, so we're on to now our accessory structures. Just keep an eye on the time. And our first one that we've got into here is our no, I wasn't taking that from the transverse fascia. The little nodules that you can see are little bits of sometimes bone fluid, a little bit of blood. Sometimes they're sometimes they get quite hard. They'll just crystalline deposits into there. What we've got here, you will hear more about this next week. But again, if ever there was a clue about what we're looking at here, and here's our psoas. So this is psoas major coming up through here. There's our psoas major. Here it is. Boom, up we go. Connecting up the diaphragm around a little star here. This is the end of the diaphragm here, end of the diaphragm here. Behind this is QL, and this is the spine in the middle of it. So we've got an accessory muscle of respiration is a psoas. Is it listed in the book? Oh, no, I don't think it is. Here's our extrinsic muscles. So where we've taken off the viscera from the inside, the rib cage has been left behind. So we've still got all the stuff like our latissimus dorsi up into here, trapezius. And if we go on to the next one as well, we got this. We got the sternocleidomastoid, important muscle of accessory muscle of respiration because of the position of the head, and also because of the lymphatics, the latissimus dorsi, gluteus maximus, and in a similar vein to what Gary did. And I should actually also big Gary up for his role in the fascial plastination project in Guben at the Gunther von Hagens. And so look out for that. It's been an amazing project in terms of what they've done. I can't wait to see the results of that. It was going to be a feature at the British Fascia Symposium this year in May 12th. It's going to be online now, so I'm not sure if there's going to be a presentation of that. But it's the fascial human. A bit of a presentation from last year as well at the fascia conference. So really cool stuff that's going on, and Gary's been at the forefront of designing the whole shebang for that. So big up for Gary Carter. He's a lovely man, a very good friend of mine, and he owes me a drink. So again, these muscles of respiration, these extrinsic muscles, anything that we're going to do with our arms or our upper body is going to have an impact on our respiration, both from a lymphatic perspective, but also from a perspective of creating space. So the position of the head is a big clear one. The stretching, yeah. You're not going to separate an adhesion with a scalpel, with a stretch. It's just not going to happen. Not like that. What I was doing there was the mechanical, functional separation of tissues, and you're not going to get that with any kind of functional movement. Once you've got something that's that pinned down internally, I think it's going to be tricky to open it up. But that was just the diaphragm. That was just the diaphragm and the parietal. There's quite a normal relationship, is how it should be. So I keep coming back to this because it's one of those things again that I just love that picture so much. It's such a cool picture. A little bit more again in here so we can start to see where we got the diaphragm blending down into the spine and psoas coming up to it. Here's the left lobe of the lung. Sometimes it's hard to know what you're looking at, but and again, likewise here. This is the beginning of where we start to see our lymphatic drainage. So the beginning, our lymph is going to go upwards. This is down to the body. This is down inferiorly. This is superiorly. This is the tail of the diaphragm blending down onto the spine. This is the diaphragm up into here. And you're going to start to see lymphatic drainage starting from here, pushing upwards into the thoracic duct. Is that what people are aiming for? I don't know. I'm not aiming for stuff. I've given up half what I'm doing. So I just want to show you a practical approach in terms of an emergency process for the diaphragm and how we can free off the diaphragm. It's a Bowen move. We've been doing it for many years. I have been in situations where I've seen people that would probably be without a doubt dead. Quite remote situations out in the bush in Australia where people are having asthma attacks, and it's situations are getting serious. I've had a couple of those. I've had a couple of local situations as well, some young people over the years, and 2 or 3 situations where there's no doubt in my mind that the people would have been certainly in a bad way. This is not a substitute for any kind of medical intervention. If anybody is having an asthma attack, then the first thing we do is call an ambulance, let people know where we are, and we get that ambulance there. But if anybody is in respiratory distress, then this is absolutely a lifesaver. And there's many people over the years. It will stop a baby colic as well. I personally believe it should be out on every single first aid course, but it's the politics of it is a little bit trickier. So have a little look and tell me what you think. So the diaphragm structures that we have join up with the transverse abdominis. So you've got transverse abdominis and deep to this, so we've got external oblique, internal oblique, and they're crossing over different lines. We've got the rectus abdominis coming all the way down. It's going to be our six-pack. And on the outside edge of this rectus abdominis, and I've got some nice dissection pictures to show on the outside of the lateral side of this, again, it's like a raphe, a very similar structure to what we have on the thoracolumbar fascia. Is we have this line where rectus abdominis is sort of wrapped up and the external and internal obliques sort of join up on this lateral side. It's very interesting. And then transverse abdominis comes underneath it. But transverse abdominis also goes up and joins up, the connective tissue, it joins up with the diaphragm. So the next layer down under transverse abdominis will be your parietal peritoneum, the sac that's is enclosing the viscera. But this diaphragm tissue is joining up almost seamlessly with the transverse abdominis. So you've got one band going this way, another band, another sheet of muscle coming this way, which is the diaphragm, and all the way along the underside of this costal margin is where you've got the joiner. So it does suggest to us that transverse abdominis is going to be very much part of our stabilization process for our respiration and should be taken into account. Well, we don't want to work it individually because we can't, but what we are going to do is we're going to work it down through this area here. Underneath this diaphragmatic area, so if we get my fingers up underneath the rib cage, and I would do this with somebody generally supine, and work my way along here, There are specific moves that we have in Bowen for this, but generally speaking, we only need to do 1 or 2. If you've got somebody that is struggling with respiration, there's an emergency situation, I have done this many times over the years, and you stop respiratory distress almost instantaneously. In my view, I think it should be taught as a first aid mechanism, because the whole mechanics of breathing and the diaphragm are very involved in this. But essentially all we're going to do in terms of respiratory distress is we're going to find that xiphoid process, which is the end of the sternum, where the sternum comes down, and I'm going to take my thumb and I'm going to push my thumb up into, as reasonably firmly, if I just move that out of the way ever so slightly, push the skin sac up, so I'm going to take the skin up, and I'm going to push into that chest relatively firmly, not onto the xiphoid process, but onto the underside of it, and pull down reasonably sharply, as if I'm sort of pulling a cord on a parachute, or one of those, when your aeroplane goes down. It's never happened. We're pushing up, pushing in, and pulling down. And what that seems to do is, it seems to, particularly in the case of where somebody's having an asthma attack where they can't breathe out, they're breathing in, all the time, and there's a lot of inhalation going on, and there's a lot of tightness in the chest, and it seems to pull down and reset that diaphragm. It's quite it's a really interesting and effective procedure for respiratory distress. Even in the case of people that are having sort of slight panic attacks, or there's breath issues going on, up and down and pulling down. You can't do any damage really here. I mean, obviously you don't need to go silly with it. You could do it again if needs be, but it should stop an asthma attack in its tracks. Obviously, you're still going to seek medical advice. You're going to call an ambulance. You can do all the things that you would normally do. But certainly, in the case of my direct experience, I know that at least on 2 occasions I've used this. Then people would probably have died before the ambulance got there. It was, you know, in quite remote settings, and it was quite an important and an urgent situation that we were faced with. And people die from asthma attacks all the time, so it's not a substitute for medical advice, so please bear this in mind. But certainly if people are struggling with their breath, then we've got things we can do with them. Basically the principle is this, is that we're going to take some what we call our skin slack, and we're going to take skin slack up to the xiphoid, the xiphy sternum. So the sternum comes down, it ends in a point. You sort of saw it earlier on my video, on the one of the pictures, and we come up. If you press into this, you'll feel the end of the sternum. A little bit down from there, you should feel the pyloric sphincter, where the end of the stomach comes into here. It's a nice area to work when you've got indigestion. Again, this pyloric sphincter is allowing the chyme from the stomach to come through to the duodenum. It's not duodenum, John Webster, it is duodenum. It's the proper way to say it, because we're not savages. And we're taking the skin slack up to that xiphoid process, and we're pulling down reasonably firmly in terms of down towards the navel, and that seems to stop an asthma attack. Now, the thing about an asthma attack isn't that somebody can't breathe out. It's that they can't breathe in. They can't breathe in. No, hang on. They're breathing in. They just can't get their breath out. So that's the point of asthma. So it's not like they're choking where they can't get their breath in. It just can't get the breath out. It's a sort of a spasm, a diaphragmatic spasm. And so try this in terms of preventive inhalers. See how you get on. There are many people over the years I've treated, and they've come back and said, "Oh, stop taking my inhalers." I don't suggest you do that for any reason, but I suggest you do this on yourself, exactly like I'm doing here. Skin slack up, push into that, and push down. The moment you start to feel any even slight restriction of your breath, a little tightness through the chest, it can be worked with panic attacks, even hiccups. My daughter Cara, she was, I think, 7 years old. Young boy's friend was sitting across the table with hiccups, and she went over, she did it on him, and he went, "My hiccups have stopped," and she said, "Of course it has." So, and now she is learning by. So I really have done this many times over the years to the most remarkable effect, and I think it should be adopted by everybody. You know, in terms of knowing how to do it, it will. You know, you could easily save a life. Yeah, with the cough, it's one of those things. I think, again, anything that you can do, and again, movement we tend not to do much in the way of movement. I'm always struck by going to the gym where people do this or this or this with their arms, but actually, you know, rotational movement above the head, just sitting there, sit and do that for you know, you may look like an idiot, but you know, you do that for 3 minutes every day, then you're going to find that you increase your vascular movement, you increase your lymphatic movement, and you are changing the way that you're driving your lungs. You know, you're creating space. Same thing goes for the head, movement of the head. The lungs are right up in here, don't forget. They're above your collarbone. They're right up into this top here. So anything you're going to do that's going to get rotational movement through your head, it is what we do, this sort of two-dimensional movement. So is the pressure centrally or off to the side? No, straight down. The pressure is right here. We'll put the movement onto there. So there is this is the sternum here. I come up to the sternum, push in straight into the center as if I'm pushing myself backwards, and I push down towards my belly button, towards my navel. All right. So that's what we do. The moment you see anybody doing that, yeah, and I think, you know, over the years, I think a lot of asthma is one of those tricky things. It's one of those things that you're diagnosed. you know, there isn't a standard diagnosis. Apparently there's no treatment or cure for it, but it's certainly one of those things that I've seen people who end up on medication that perhaps, you know, perhaps they didn't need, or they grow out of it, or I've had recent experience with children who don't have any symptoms and haven't had for a long time. Do they need the medication that they're on? Well, they're not taking it, so maybe not. Again, and that, yes, there was the interpretive dance. You see, you got that. But there's something to be said about it. You know, how much of our daily activity of our life is spent. You know, might go to the gym for half an hour, but we're not picking apples or grapes or dancing or doing, you know. So hands above the head and moving around. Try it for 3 or 4 minutes and see how your breath changes. There's so many links in relation to the position of head. Forward head posture is linked to a whole range of stuff, whether it be from depressive illnesses to loads of other things. So about gravity bringing blood supply to the lower limb, I'm going to how did I discover that? This is a Bowen move, and I've been doing Bowen for over 25, 30 years. So this is a really useful thing. So gravity to the lower lungs, so inversions recommended for reversing this. Yeah, I mean, whatever works for you, really. You know, is this only an emergency procedure? I would say it's one of those things that once you start to feel a bit tight in your chest, you can do it. I might use it for indigestion. If I go to bed late at night with a bottle of whiskey in my stomach and I get a bit of indigestion, you know, then Hannah says her daughter's recovery from asthma through Bowen therapy is what inspired me to train. So excellent, that's great news. So yeah, anything that you can get that can get you going. Well, you don't know whether it's Mr. Bowen, but it's certainly what we call Bowen these days. It may or may not have been him, we don't know. But anything that you can get that's going to increase your range of movement across your body is going to be the thing to do. But anything, again, in this area here is going to link. You can't get through the rib cage, but you certainly can get through the neck and shoulders. I'm going to be doing some stuff for some Bowen people again, but anything up around the sternocleidomastoid, getting the lymphatic drainage going to there. So, guys, thank you very much indeed for dropping by. I'll stay in the chat room and for a little while, for a few minutes. So thanks for coming. Thanks for registering. I'll put that video again up on YouTube. We'll send a link out. I'm not sure how we do that necessarily. Please join me next week for the SOAS. We're going to have some great fun with that and have a little look at some of the things that we're talking about whether we can press through the abdomen and reach it, and if we can, what we think we're doing. I don't know. It's been a blast. As I said, it takes me about 2 or 3 days to get all this stuff. I'm sifting through. Please, if you have any suggestions of things that you'd like to look at, or subjects you'd like to cover, or bits of the body you want to talk about, I know, I've got mountains of stuff that I want to show you and share with you. So if there's anything you'd like to see as a subject for a webinar, then please let me know. All suggestions gratefully received. You can email Cara. Thanks very much, Cara, for being on the moderator panel tonight. I don't know where she was, but she's there. And so join me next week when we sort of start to see if we can find a core. We're in search of the mythical core. So we'll catch a unicorn, find the pot of gold at the end of the rainbow, and find a core. Yeah, been great. Thanks very much, guys. See you next time. I'm still in the chat room, so if you want to stay and say anything else, then please let me know. Okay, bye for now. Do I have any more? Where we go? I don't know anything about Perry Nichols.